Thank you for attending my presentation on the impact of post-seclusion and restraint debriefing on an inpatient child and adolescent psychiatric unit, a quality improvement study. First, we're going to talk about what seclusion and restraint are. Basically, Joint Commission defines them as the use of chemical, mechanical, or physical methods intended as a last resort to control aggressive and dangerous behavior. So the key term here is last resort. Basically, we don't want to use these as a means to prevent behavior or as a means of punishment, but really when there's an imminent threat due to aggression or self-harm. And I think we do a nice job of this at our facility. We use it properly. So some statistics related to seclusion and restraint. One study showed that 22 to 47% of children and adolescents are being restrained or secluded on child and adolescent psychiatric units. I think that's a really, really high number, 22 to 47%. Another study showed 26%. So, really high numbers here. Some consequences of seclusion and restraint. One study showed that, seclusion and restraint has been shown to cause psychological harm, physical injury, and in some cases even death. I mean, of course, I think you can see how that could happen. Another study showed that it can be traumatizing for children with a past history of trauma. And then there's some data, it is older, from 2006, but it's the only data out there of its kind. A study found that between 1993 and 2003, there were 45 fatalities on inpatient child and adolescent facilities related to seclusion and restraint. I feel like that's a really high number. So it's certainly a good reason to try and get our numbers down. So when I went and looked at the data, and did some research, I looked at what SAMHSA had to say about how other programs are getting it done to reduce seclusion and restraint on their units, and they work together with the National Association of State Mental Health Program Directors to find strategies to reduce seclusion and restraint numbers. And they came up with the 6 core strategies, and some of the strategies were like using data to inform practice and workforce development. And then one of them was doing a debriefing immediately post-seclusion and restraint with the patient, which we do right now. It's part of the orange packet. We meet with the patient after the RN meets with the patient after a seclusion or restraint incident to talk with them about what happened. However, SAMHSA also recommends a second debriefing that occurs within 24 hours after that incident to go over it again. So that's what we're going to try to do for this project. So right now, I feel like we're using seclusion restraint quite frequently at our facility, and I'd like to use these recommendations, to reduce our numbers. So what I did was, after looking at the SAMHSA guidelines and seeing how debriefing can help reduce seclusion and restraint, I went and looked at our orange packets to see how good of a job we're doing at our debriefing tool, and I looked at our tool in the orange packet from January and February of 2021. I looked at 30 seclusion and restraint packets and found that 84% were done incorrectly, or 25 out of 30. 20% were just writing refused, patient refused to participate. 16% of these were completely blank. And 63% did not speak to the patient and wrote things like, quote, patient was aggressive, or denies, or refused for all answers. So I feel like we can do a better job of this. So that is the proposed intervention, to do a better job at our current debriefing system, but also to add a second debriefing that will take place during treatment team with the provider, the RN, and the therapist present. So basically, when we do a debriefing, it should be done in a non-punitive manner. We should meet with the child. The goal is to re-establish the therapeutic bond, to talk about what happened and how it can be avoided in the future. We don't want to shame them. We want to build them up. We want to be like, hey, you know what? You got this. You can do this. How can we help you to be better? How can we help you to avoid this in the future? A lot of these kids are not coming from the best backgrounds. They don't have the support. We want to be their support. We don't want them to make them feel guilty and bad and ashamed of what they've done, okay? So just a little checklist about what we could talk with them when we're doing a debriefing. Just ask them about what their triggers are, what caused them to act out. What can they do next time to avoid the situation? How can we help them to avoid the situation? Do they have any warning signs that we can watch for? What are some of their coping skills? Um, and always ask about how they're feeling emotionally and physically. Especially physically, if they have any injuries, we definitely want to address that, refer them to medical team, okay? And then when patients are admitted, we always do a safety plan with them, so we can always refer to that. And then also always consider offering them, time in a quiet room, journaling, making bracelets, watching a movie, music. We don't want to be rewarding them for bad behavior, but these are ways that things they can ask to do next time to avoid popping off, to avoid having a code, okay? All right, so let's get to the documentation. So this is the orange packet that we all know and love, okay? So providers, you're going to sign off down here. This is what we should be looking for during treatment team to sign off on these. And also it will be a signal, like if there's one from the day before, that we should be meeting with this child to do a debriefing, okay? So providers, basically look for these packets to sign off on the ETO, and then consider it an opportunity to meet with the child to find out what's going on with them. It's a great opportunity to titrate medications, change treatment plan, really understand what's going on with the child, what their thought process is. And then any documentation about the debriefing should be done in the narrative portion of the yellow progress note. It's pretty self-explanatory. Okay, and then the debriefing tool for the RNs. Let's back up a little bit. So this is the entire debriefing tool for our RNs. Okay, the top portion is the staff debriefing, and the bottom portion here is going to be the patient debriefing. Okay, so up here, the staff debriefing, that portion should be completed before the code clears. So when we have a code for an ETO, the staff should always get together and talk real quick, make sure everyone's okay. Make sure, talk about what could have been done better, talk about what went well, hey, good job, stuff like that. It's a great time to build rapport with each other, get to know new staff members, great time to educate, etc. Another reason is staff get hurt too, staff get traumatized too. So basically, there was a study from 2005. Basically, 70% of nurses working on inpatient units have been assaulted at least once by patients during their career. This is a really high number, but I know that there is a lot of violence going on, in patient psychiatric hospitals, okay? So we need to just check in with each other and make sure that we're okay. And then, if there's stuff going on, that we get referred to the right personnel at our hospital, okay? So this is what the staff debriefing looks like. We're going to just put the names, the people that were there. This should be done before the code is called. And then the patient debriefing, that's this portion right here. So basically, meet with the patient after the ETO is given. Try to get with them as soon as possible so they're not sleeping yet. I know we use a lot of chemical restraint. Basically, so question one, we want to talk with them about what happened, their perception of why they popped off, why they were hurting themselves, whatever it was that happened. Number two, what happened, their version of what happened. You never know what they're thinking. Number three, anything that they could have done differently. Number four, were their well-being, psychological comfort, and right to privacy maintained? If the answer is yes, you can move on. If no, we're going to refer this to nursing supervisor, okay? Was any trauma experienced by the patient? If the answer is no, we're going to check no. If the answer is yes, we're going to refer this to nursing supervisor and clinical director, okay? Strategies to prevent repeated use of intervention and/or address factors contributing to the incident. So we're going to ask them what they can do better next time. So we're just going to ask them, hey, do you have coping skills you could use? What can we do to help you? And just write that down in there. Okay, so I think, and we're going to sign date and time, but I think the biggest challenge with this is the patient is usually sleeping when we're trying to do this, or the patient is still angry. And I know it's hard to do. I get it. I've been there. We need to try to get with the patient before they fall asleep, or we need to get them when they wake up, or pass it to the next shift. It needs to get done because the data shows that this is going to help prevent this from happening again. It's not just a piece of paper that we fill out. It's something that actually has been shown to work historically, okay? So the data shows it works, so we need to do this. So let's pass it on to next shift or do our very best to complete it, okay? And definitely try to talk to these kids. I know that I think they're more willing to talk to us than we think they are, and I think they would like a chance to kind of just get with us and maybe come back and say, it's okay. I know you were upset, and give them a chance maybe to like reestablish that bond and let them know, hey, it's okay. You know what? We're still there for you. So, before I conclude, I just wanted to say, mental health technicians, you guys are a super important part of this process. That's why I included you in my project. You guys are our eyes and ears out on the floor. You're on the floor with the patients. You know what's going to happen before it happens. And, we always value your input. If you feel like something's going to go on, and you feel like something's coming, please come into treatment team, come in and see us. Let us know, what you think is going on so we can try to intervene ahead of time. And if you guys want to get with kids after these incidents to try to talk with them, totally cool. Also, you can get with them, let them know you're still there for them, you still care about them, you still, you have their back. We want to build these kids up and let them know that no matter what, we're there to help them, and that's why they're here, so we can get them, more functional and living happier lives. So I just want to, this is my bibliography if anyone is interested, and I just want to say thank you so much for participating in this project. I truly appreciate it. Thank you.